been himself a major player in the realm for the last few decades. Just to go over his work, in the 1980s, he served as the director of the Development Institute at UCLA African Studies Center. And in the 1990s, he served as the director of policy and planning at World Vision International. In 1999 to 2005, he continued on as the senior human development specialist at the World Bank, as well as a social protection consultant. And in this role, he co-wrote the World Bank's World Development Report in 2004, established the World Bank's Children and Youth Cluster, as well as developed the standards for managing dimensions in economic crises, good practices for policies and institutions. After that, he served in various consulting as well as advisory roles in organizations such as International Medical Corps, Overseas Development Institute, and more. His work in policy and systemic change spans from youth education in South Sudan, post-conflict water security in the Middle East, disaster and safety nets in Laos, and just many, many more. Currently, he is the Associate Director of Global Public Affairs here at the Luskin School for the past 8 years, as well as the Director of Public World, which is an international consultancy committed to good work, democratic citizenship, and human rights. Additionally, on that role, he works at the World Bank as a climate and water analyst and is the lead technical facilitator for the World Bank Center for Mediterranean integration. So without further ado, Dr. Commins, do you think that was, did I miss anything?
You said too much. You said too much. So people have already heard me at base camp and maybe seen me with my Looney Tunes mask. So I'm just going to jump into the program. Today's talk is focusing on global health players. And I want to emphasize that this presentation and our discussion really ties into the core of what we want to do with the entire Selective, which is to look at issues of inequity, justice, how power is distributed, and how social determinants of health affect health outcomes. Now, critical to understanding, just so you know, I've moved the slide down. Did the slide move down on the screen, everybody? Does it show global health players and power?
Yes. Yep.
Okay. So power is a critical concept to understand health policy. For this session, consider last week the voices that we heard about decolonizing global health, the voices that you heard about community involvement. And always let's remember that while I'm talking about global health players, power within health systems is an issue not just in Malawi or Peru or Bangladesh, it's also an issue in the United States. So within the course objectives, we have a number of major themes we're looking at, all of which tie back in some way to our core concern about justice, equity, and power. So you heard decolonizing global health, which was a very powerful and rich discussion. We've had involvement now with the community engagement session. Moving forward, when we look at human rights, I'll discuss a little bit today why the human rights lens can be very controversial and why the human rights lens is an important way of thinking about global health, but also why a lot of global health players don't want to talk about human rights. You'll be talking about the Gates Foundation, which is a massive player in global health. But when we look at the issue of power, the decision-making of the Gates Foundation is by a couple of people. Now, what happens in the future, whether it's Bill Gates or Melinda Gates, we don't know. But in any case, billions of dollars spent every year by the Gates Foundation are not funds that are voted on by low-income communities, by women's groups, by disabled people, or anyone else. The global burden of disease is an important piece to understand that the manifestations of ill health come up differently in different countries. And when I get down to looking at how global health systems are funded and who plays a specific role, one of the challenges we'll look at is, do you provide funding around diseases or around health systems? You also have a session coming up on climate disasters. Climate change increasingly affects health, and yet I could argue, and many other observers would argue, that the current global health system and the key players give rather small attention to climate. Coming back up to decolonizing global health and community engagement, it's really a reminder that, as with the blind people trying to identify the elephant, often our understanding of power and privilege is shaped by the perspective we come from or the blinders that we wear, whether it's patriarchy, white savior complex, the nature of colonialism, or the lack of diversity within global organizations. If the global organization is run by the women and men who are white wearing the gray flannel suits, are they really in a position to make the decisions that best benefit people who are most at risk of ill health? Talking about global health players, the core organization that has the responsibility for global health is the World Health Organization. Now, what I want to emphasize is that while the World Health Organization has primary responsibility, it's not the organization with the most money, or the second place with the most money, or the third place with the most money. And this is not uncommon in international finance, whether it's health or water or education, that the technical organization most responsible for the field, think of the World Food Program or UNICEF for children's education, or UNESCO in general for education, they frequently are not the organization with the most money. So you can see here, WHO has a number of very important technical roles at a global level. We have seen recently enormous political contestation about the role of the WHO in relation to COVID. Should it have declared a health emergency sooner? Is it too influenced by China? Is it too influenced by the United States? Is the director of WHO too influenced by the Ethiopian government, which where he comes from? So these political debates are important to understand, because while we can see on this slide many key technical roles for the WHO, it's essential to recognize that WHO is never buffered from political issues. And in fact, a particular aspect of WHO is that its budget comes from governments. It does not have an annual UN budget, so it has to depend on the United States or Norway or Sweden or Japan or China to put the money in. And you may be aware
Eve, I'm so sorry. I don't know if you can hear me, but we can't hear you at all. I think you lost connection.
or have you lost the whole thing?
Oh, now we can hear you. We couldn't hear you before, but now you're back.
Okay, that's strange. Okay, so just to repeat, the WHO is theoretically a technical organization. And by the way, Vijay, if you lose me again, let me know, okay?
Will do.
The WHO is a technical organization, but deeply tied up in the politics and in the financing of health. So this list of its roles is essential, but its roles don't remove it from the politics of global health. Now, there's many other UN organizations which also play an important role. What's interesting, and I highlighted it, is PAHO, the Pan American Health Organization, was established before the WHO. So unlike the Asia or Africa or Middle East regional offices for health, which are in fact very small and not very powerful, PAHO is almost an independent office. Now, WHO wouldn't tell you that, but if you look, if you're in health in Latin America, PAHO produces really excellent research and resources and has much tighter relations with government in Latin America than the other regions do. You can see on the screen the UN High Commission for Refugees, the World Food Program, UNICEF, the UN Fund for Population Activities, and UN Women. All of these in their own way have an avenue in which they contribute to health, but they do not set health policy. All of that resides with WHO. Now, what's interesting, we'll come back to it later in this discussion, but also this sets the groundwork for your session on on human rights. The right to health is within the WHO Constitution. And you can see here, I can get my little cursor to work, go. The fundamental rights. Yes.
Sorry, we lost you, but we got you back.
Okay. The fundamental rights of every human being. No other organization, none of the bilateral donors you'll see, they may talk a bit about rights, but this particular statement is very important. And notice the first sentence, it's not the absence of disease or infirmity, it's a state of well-being. And I think that's really important to recognize as a foundational point, thinking about what role global health organizations play, and also coming back to last week, what we can ask in terms of what local communities think about their own well-being. The major multilateral development banks, the World Bank, Inter-American Development Bank, Asian Development, African Development Bank, all play a major role. By far the largest of these in terms of funding for health is the World Bank. For different reasons of their evolution, the other three banks have tended to finance infrastructure and large programs. The World Bank is the largest provider of health funding. In fact, it'd be interesting in the last couple of years to see how they compare to the Gates Foundation. Now, one critical thing to know is that all of these institutions are banks, which means the money they provide to Brazil or Peru or Malawi or Zambia are not gifts, they're not grants. They're either loans given at low interest rates, below market, or they're credits, and the credits are 0.5% or 0.3%, which is very low interest, but they still have to be paid back. So there's many debates about providing loans for health, even if the payback is 25 years. Now, these institutions, especially the World Bank, have very large windows that provide grants. And these are specific funding pieces that often, for example, right now, there's a very large COVID fund. There was a time, the first 10 years of the 2000s, there was a program called MAP, M-A-P Africa, the multi-country AIDS program, which provided a lot of grants. Now, the bilateral organizations are massive. There's over 25 different governments, not just those listed, which would be the United States, Canada, DFAT, which is Australia, FCDO in the UK, which used to be DFID, JICA, which is Japanese. One thing I would point out, and I put it here in a different color, is that most European governments, of course now the British UK is not part of the European Union, but most European governments put a significant part of their international assistance to the European Union. So it's a very complex system to consider where does all the money come from. All of these agencies have their own priorities. They don't align necessarily one to another. They all have regional priorities. So for example, Canada has always had a long interest in Africa, whereas Australia has really withdrawn from Africa, and their largest programs are in South Asia or in the Pacific. Japan, very much in South Asia, Southeast Asia, Pacific. Now, another thing to think about when we think about global disease and players is to ask, where does the CDC or National Institute for Health fit in terms of drugs, in terms of disease surveillance? Because the CDC does disease surveillance, not the United States Agency for International Development or the Office of Foreign Disaster Assistance. So even within one government, say as the United States government, there's actually a lot of different factors to go. Now, the difficulty, if you go back through all of these agencies and think of all the players, you have a problem of coordination. And this is a slide I really like, because it's a reminder that you have all of these global health players, but how do they work together? In what ways do they work together? And sometimes you find in an individual country, say Peru or Ghana, or not necessarily India, but say Thailand, there are national health coordination bodies or national health platforms where, say, the UN gets everybody around the table to talk about what their priorities are. Because otherwise, what you have is 40 or 50 different countries giving money for different reasons, and we'll come back to that later. Now, the foundations, we know about Gates. Other major foundations include the Wellcome Trust, which is in the UK, the Rockefeller Foundation, the Vaccine Alliance, the Hilton Foundation, which is right out in Agoura. So it's the one major global foundation in Southern California. There's lots of foundations in Southern California. Hilton's the only one with a large global program. And then Bloomberg has given hundreds of millions of dollars to the public health programs in Johns Hopkins. So all these foundations are important. The big elephant in the room, which we'll be examining, is the Gates Foundation. And the controversies around the Gates Foundation are, number one, it's really two people or one person making the decision about where the money goes. And secondly, it's so large that it can skew what other foundations do or decide to do. The private sector is also a big player. And I just mentioned a few areas where the private sector is massive. It's often not thought about, but the World Bank or WHO or the US government or the European Union do not develop drugs. Drug development, it may be funded and financed by governments, but generally, except perhaps in China, big pharma is in the private sector. And yet it's important because the essential medicines to treat HIV/AIDS, malaria, TB, deal with COVID, all these other medicines are developed by private companies, and that leads to some complications. Beyond what we would consider sort of health and medicine or the medical field, the private sector plays huge roles in other areas. Number one, in many middle-income countries over the last 30 years, there's been massive controversy over privatizing water. That is, that the water service in Buenos Aires or the water service in Dar es Salaam is taken from the government to a private company. This is not going to happen in rural villages, but often in the largest cities. And this raises big questions about the pricing of water and also who ends up getting water service delivered. Very poor people can't pay for it, so how do you do that? I mentioned food and nutrition because in many countries now, you have what you could call the two faces of malnutrition, where some people suffer from malnutrition in the sense of a lack of protein and calories in their diet, but other people have overnutrition because the food system now includes lots of types of potato chips, fast food, Coca-Cola, other sodas. And so the role of the private sector in terms of health can be very significant. We think about COVID. I don't know the exact research that's been done, but I've seen a number of articles in medical journals and blogs and science blogs, and these indicate there's a strong comorbidity between COVID and diabetes. And diabetes is very much related in some instances with obesity and with diet. Now, the last one I put on was social media, and that's because social media, unfortunately, is often a place of misinformation about health, not only in the United States, but in many parts of the world. So we talk about players in global health. There's the formal players, but there's also informal players who may have a very different role. Now, I wanted to stop for a second because this is really important in terms of the players, particularly the World Health Organization, but also the World Bank, groups like the British and UK and US government, because this gets back to the right to health and the essential medicines. Because with the COVID vaccine, for example, or previously with ARVs for HIV/AIDS, this has been a major source of contention between the WHO governments, especially the United States, but also the German and UK governments, countries with large pharmaceutical industries. And it very much ties into the right to health because the commitment to essential drugs is very linked to people's right to health and to be protected from severe or fatal illnesses. This is a very interesting piece because, as I'm sure you're aware, there's not a vaccine surplus in South Africa or Zambia or Malawi, but there's lots of vaccines in the United States, UK, increasingly now much of Western Europe is vaccinated. So the debate about sharing vaccines or vaccine justice is very much linked to this issue of essential drugs and what is the right of people globally, not just in a few countries, to have these. Now, other big players are non-governmental organizations. And I put up this slide because it's a bit amusing to me how many different acronyms there are for non-governmental organizations. And yeah, I always like bongo because it sounds like a drum. There's no degree terminology for NGOs. However, most of you have heard of them. For example, a very well-known health NGO is Médecins Sans Frontières. One of the largest NGOs in the world is CARE. Save the Children is also very large. International Rescue Committee, the Africans for Humanitarian Action, Bangladesh World Advancement Committee, which is in effect actually a $1 billion NGO. NGOs play a vital role in a couple of areas. One is, particularly in countries with weak health systems, NGOs are often the frontline deliverer of health services. They run health clinics, they run vaccine campaigns, they're very involved in the delivering of health services. Secondly, some NGOs, Save the Children would be a good example, advocate. The Save the Children Federation would push the US government, the UK government, the World Bank, the European Union to allocate more funds for specific types of health programs. So often they play a role not just in delivering, but being the voice of concern about areas where health services are not being delivered. Now, I put down below a note to identify two major actors in the health field that often get lumped in with NGOs, the International Committee of the Red Cross and the International Federation of Red Cross and Red Crescent Societies. They are not NGOs, but I put them on the same slide, so hopefully you'll remember they're not NGOs, which may be counterintuitive. The International Committee of the Red Cross is the only international agency recognized by treaty as the humanitarian agency with the right to, for example, visit prisoners of war, with the right to treat wounded civilians and soldiers across battle lines. ICRC has the Red Cross as its origin, and it is based in Geneva, and it is, in a sense, the custodian of the Geneva Convention. Now, just to confuse you, the IFRC, which only has one separate letter, is the global federation of all the Red Cross and Red Crescent societies. So after the founding of the ICRC, volunteers in the United States, United Kingdom, other countries set up their own Red Cross, and in predominantly Muslim countries, Red Crescent societies. They are recognized by their country governments. So the American Red Cross, for example, through an act of Congress, has a very specific role. The same with the British Red Cross or the Turkish Red Crescent Society. So you can only have one Red Cross or Red Crescent Society per country. And then through the International Federation, they do certain joint programs together, many of which, for example, a friend of mine and I were talking today about polio. But for example, IFRC is very involved in polio campaigns in Pakistan. So they're major players in terms of delivery of services, but they're not the financer. So I want you to think about a few things as I go through a bit more of the implementation of the work of global players. We're going to look at the 8 complexities in coordination in DRC. These are slides that I showed at Basecamp, but I think they're worth looking at. Then you have 8 complexities in sustainability. Who's going to fund health in Liberia? With global burden of disease and vertical programs, when you have diseases such as malaria, tuberculosis, HIV/AIDS, quite often governments will fund specific programs, which are called vertical programs because they go top to bottom around one disease. And they may be very good programs. The problem is they don't provide any money for anything else. So I believe I mentioned, but I'll repeat that a number of years ago, I was in a workshop at the London School of Hygiene and Tropical Medicine on health in post-conflict countries. And someone from the WHO was there. He said he'd been to Zambia and the country had been PEPFAR. PEPFAR is the President's Emergency Program for the response to AIDS, which is very good. But what he meant was when he went to clinics, there was resources for testing for HIV/AIDS, for counseling, and to provide the antiretroviral, but there was nothing to help with malaria. So there's a fundamental problem with the health players if they're putting money in without helping the overall system. Now, one of the things that comes out from decolonizing global health is what is the accountability or social accountability of the global health players? Going back to last week and the presentations on decolonizing global health, the discussions about community engagement, part of the discussion is a recognition that there is this system, whether it's the United States or other countries, where decisions are most often made at the top. The accountability to people who are supposed beneficiaries is small, if at all. And this leads to a very critical question when it comes to Gates, but also others. Are foundations accountable? And generally, the big criticism of the large foundations is they're not. So the dependency on vertical programs means you have these diseases of the month, you've been PEPFAR'd, and also this big challenge that the budgets are determined outside the country, that the citizens of Malawi or Peru or South Africa have no voice in where the money comes from. Now, there's been efforts. There's what's called sector-wide approaches, which is supposed to help the whole health system. Pooled funds where all the donors put their money into one basket. Public financial management, where they try and track the money better, but put it through one direct budget support. But this piece here is really important remember when we think about decolonizing global health, who gets to make the decision? Now, I showed this last time at the base camp. It's a pretty daunting slide. Since I'm going to share it, everybody can get a copy, and you'll just see the number of different people who are getting involved in health in the Congo. And it's almost impossible to manage. So in this case, the global health players are many, but the resources at the local level are few. Now, similarly, I mentioned that in Liberia, the emergency health that had been provided to this country coming out of a 15-year civil war was all going to run out in an 18-month period. And so this slide was actually used at a meeting of the World Bank, the US and British government and EU, by several of us who were doing research on health in post-conflict countries, to say your plans are completely illogical because the government of Liberia cannot pick up the slack in 16 or 18 or 20 months. And fortunately, a very important decision was made going back to this phrase. A pooled fund was set up for Liberia, which was exceptionally successful. And so these lights not only stay green, but up until the Ebola crisis, which unfortunately set back so much of Liberia and Sierra Leone, not least through the death of many health workers, these lights stay green. We've talked about accountability and the accountability of the global health players. And I've set out some things that within service delivery within a country, it's possible to get citizen groups more involved. Decolonizing global health is citizen engagement, is citizen participation, is having the first voice be people in the community, not them at the end of the long chain getting the money that somebody else has contributed. So going back to the decolonizing global health, I thought it was a really good discussion. I think it was Sandeep Gupta who talked about the trade-offs that have to be made. Now, this is a quick and dirty list of things because it's actually more than that, and you have to look at the organization because it'd be different between a foundation and an NGO in the world. But there's lots of different roles. And I would note at the bottom two roles are much more like what was talked about last week, which is looking from the bottom up. And then you have to ask yourself, what do you want to do? Where do you want to live? And what kind of careers do you want to have? How do you work in global health? Now, the difficulty is that global health, or the whole global landscape, is in the process painfully of being decolonized, but it's not there yet. And in fact, there are many ways in which the global health system reflects the old colonial mentality, which is why I love this slide so much, to sort of say it truly is a colonial system. Now, it's not quite that bad, but there's a painful truth in this. So in thinking about the global health players, and the other sessions for the selective, we think about whose voice and whose choice, who is really involved in making the decisions. And as you reflect back on the program last week, as you look at other discussions going forward, I think it's pertinent to recognize that all of these different sessions relate to each other in a significant way. And I think it would be good for you just to recognize that when you look at the slides from this presentation, they tie into something well. Now, my last slide is to remember a really wonderful and dear friend of mine. There's a Charles Wacker scholarship at UCLA. Charles died in 1983, which is a long time ago. He was a med student at UCLA, and he had an aortic aneurysm, which was fatal. And I try and remember him these many years later, because when I come to the meetings, as I did last last week and see all of you preparing for your careers, I want to remember that he was a young man who wanted to go work in Nicaragua after he finished. And for 38, 39 years ago, had that commitment to global health. Now you were all carrying forward. So those are my comments. I'm glad to take questions and feedback, complaints, and I'm done.
Thanks so much, Dr. Commins.
Thanks so much, Dr. Commins.
I'm having a little bit of a delay as I'm speaking, but hopefully it'll be okay. I forgot before we started to make guys a formal introduction for our MS2s that are helping to lead this course as well. We have Kesha, whose camera is on now, Colin, and I believe Joy is here as well. She was here for a minute. But I definitely wanted to make a point of introducing them. Oh, there she is. They're going to also be leading a lot of the small group discussions that are going to be peer led. So I will let one of them take the Q&A from here.
Hey, Colin, could you drop me off being the center of the screen because it's making my computer do funny things. It probably doesn't like my face. There you go.
Okay, so I guess we'll start with the Q&A. So thank you so much, Dr. Commins. That was an incredible lecture and very, very informative. So we just wanted to open the floor to all of you guys. If you have any questions, you can go ahead, unmute yourself, talk, or you can drop it in the chat and I can ask it for you. I guess I can start off with a question as well, actually, that I've had is, so I remember even when I took the selective last year, one of the big questions that I had was, how as med students can we get involved with such a broad topic in terms of getting ourselves involved with global health systems? How can we become like advocates in your opinion?
I would say it depends on where you want to make the impact. So there's several different things to think about. One is when you do your community engagement in Southern California. Can you hear me okay? Okay. So when you get engaged in Southern California, you're doing global health because the level of poverty, the level of health needs in Southern California are such that it's not different. Secondly, it depends on whether you want to do advocacy. If you want to advocate, let's say, for more US government funding for certain types of health programs or bottom-up health, there's plenty of advocacy organizations, and I can do a little update, talk to a couple of friends of mine in Washington who probably have the best current knowledge of who's doing the best work because they do lobbying, letter writing, visiting representatives. The third thing you can do is sitting in Southern California as med students, you can ask if Karen Bass or Ted Lieu or other representatives are on the congressional committees that deal with health. So if they're on the Foreign Affairs Committee, and frankly, it may seem surprising in a state like California, but often these representatives and their staff get very little input on health issues. They're not experts on that. So you might find that Ted Lieu or Karen Bass or somebody else is very involved on some global health issue and would love to hear from someone from UCLA getting involved with that. The same would be for the senators, Feinstein and Padilla, or either of them on committees where they're making decisions. The US government, certainly the current government, is going to spend more money on global health next year than has been spent at any time ever, and certainly in the last 4 or 5 years. So how is that money going to be spent? Is it going to be spent in programs that are not very well thought out, or they can be spent in programs that are really well developed? So your congressperson, your senator, people don't even think about that. I will check to see who is doing the most interesting work.
Great, thank you. I think there's a few questions that have popped up in the chat, so I'll just read them out so that we have it for the recording. This one's a bit of a clarifying question, but what are some specific steps that are being taken to decolonize the global health funding system?
The specific steps depend on the organization. So let's take a group like BRAC, Bangladesh Rural Advancement Committee. They have moved much more towards a global system and structure with people from Africa and South Asia in the lead. Oxfam International has now a global director and a system designed to work from Africa. ActionAid, I believe, moved their headquarters to South Africa. That doesn't solve everything, but it does begin to change that. So that's one thing that I think is important. Secondly, in Europe, much less the United States, there's a very broad movement to demand greater accountability for philanthropy. That the organizations are, need to be accountable to the communities where they spend money. There's also different global health advocacy groups that have emerged in Africa, in South Asia, and Latin America that are pushing their own governments not to accept money with certain strings attached.
Okay. So there's another one here as well. If you could just speak to how US-based medical schools are fighting over grants and funding in vertical programs and how this is impacting different programs as well as countries.
Fortunately, I'm not an expert on how medical schools fight each other because I might get in trouble when this tape might get out to medical schools. I think it's a really important question. I guess I would flip it around and say, can there be a dialogue among medical schools to rethink how they get grants and funding for programs outside the US to create a more holistic approach so that while the medical school may get funding around malaria, TB, or HIV/AIDS, it's done much more in a broad-based health spectrum rather than a vertical program. I think it's a great question, and it does come down partly to the ties between NIH, med schools, and other funding sources. But then I think it has to come down to the medical schools individually and collectively rethinking what their impact is. Is it just going to be whoever, I have a old sarcastic comment about NGOs that when the blood is spilled, they all come running like hounds to get the money. And I guess, medical schools unfortunately have the same incentive. So you need a dialogue about that.
Right. Okay, so we have, thank you guys for putting the questions in the chat. It's really appreciate it. There's some really good questions in here. So I'll just read out the next one. For another student, it's a little bit confusing is how funding decision-making at the World Bank is currently voted on by representatives from different nations. And maybe I'm not sure about this, but if the number of votes each nation gets is dependent on the GDP of each country, is the inequity, so the policy and funding decision-making built into such a system being considered?
So first of all, it's a highly unequal system because it's not by GDP, it's by shares, which is somewhat similar to GDP. So the US, UK, Japan, China, Russia have a seat. It's not completely that way because, for example, Brazil has a seat. There's 24 directors. Of the 24 directors, 2 are from Africa. So your business card would be really interesting because you're the director for 23 countries. So, and there's been a lot of debate about that, about shareholders, about the board of directors. Nothing's changed, and that's partly because there's what I call the devil's deal between the US and Europe, that the US gets to pick the World Bank executive and Europe gets to pick the executive for the IMF. The thing I would emphasize, though, having worked in the Human Development Network for 7 years and therefore done the quality review of all the health proposals, they're not really voted on in the sense that the board operates generally by consensus. So having been in many board meetings and projects were discussed, if the representative for East Africa or West and Southern Africa made a comment that would be taken into account the same way as a representative from Russia. So generally, the biggest problem is between the negotiation between the World Bank staff person, let's say doing a general health support project for Tanzania and the Tanzanian government. And the difficulty there is often, what are the incentives for the World Bank staff person? And so it's much more a bureaucratic incentive. I need to get this project approved. I want to show in my baseline. So it's actually less the power than it is the money. If your goal is to get the money out the door, then you may make compromises in the agreement that you shouldn't make. And believe me, I've seen that and been in contestation discussions about those things.
If anybody has any other questions, keep putting them in the chat or go ahead and unmute yourself and ask.
I think people have to get to afternoon classes. So what I would recommend is that maybe we could continue the discussion, hopefully on the blog. I'm going to try to cut and paste some of these questions there because I think it is worthwhile to continue to have conversations around these topics. And just wanted to let you all know too, we have our small group peer-led discussions on Wednesday. It's going to be very exciting in person. We'll meet outside of Revive Cafe, get our lunches, and then just sit outside in small groups. If anyone has any questions, just let us know. I think Vegeta is going to put a link to a very, very quick survey just to give feedback on Dr. Commins' wonderful talk in the chat. So you guys will have that. And is there anything I'm forgetting? Oh, there's the survey. She's also going to send it by email. So if you feel that you're rushed and you need to go to your afternoon class, you can do that. Thank you so much, Dr. Commins, and thanks, Keshav, for leading the Q&A, and Colin for doing the introduction. Great event. Thank you.
That was fantastic. Thank you.
You're welcome.
Have a great day, everyone.
See you in a couple of weeks.